Dr. Aruna, shall we start?
Please start.
Okay. So, good evening, everyone. Once again, we are back, 7th of every month. So, 7th April, 7 p.m. for 70 minutes. So, we'll have a very fruitful and productive discussion in these 70 minutes. So, today we have a very interesting webinar on CIN in pregnancy and other special populations. So before I hand it over to the conveners, I would first extend my gratitude to Dr. Pratima Raj, who is the convener of today's session. She is a gynec oncologist practicing in Manipal Hospital in Bangalore and a robotic surgeon. So thank you, Dr. Pratima, for convening this webinar today. And so before I hand it over to the organizers, I would request our President, Dr. Aruna Nigam, to give the welcome address. Over to you, Dr. Aruna.
Okay, thank you, Dr. Vindhya, and thank you, Dr. Pratima, for taking this responsibility to organize this month's monthly webinar. So, after a hectic last weekend, which was there, we all spent at Chennai in ISCCP Con 2026, which was full of academics, a great cultural event, and a wonderful valedictory and inaugural ceremony in which we have released 2 books and we have felicitated all our fellows of Colpo course as well as vulvovaginal disorder. So just to let you know that from tomorrow onwards, the next batch of fellowship course is going to start, and the training course on vulvovaginal disorders, that is V Insight module, will start from 1st May. Registration for both of them is open. And today is the 7th April. So a very happy World Health Day to all of you. The theme for this year's World Health Day is Together for Health, Stand with Science. So focusing on global scientific collaboration and one health approach to protect people, animal, and the planet. Just to remind that why we celebrate World Health Day every 7th April, to commemorate the anniversary of founding of the World Health Organization on April 7, 1948. First, it was observed in 1950, and this date serves to draw global attention to specific critical health topics, promoting awareness, action, and healthier lifestyles worldwide. So that's what we are following that in our ISCCP, and that is the motto of our, that we need to improvise the cervical health. So with this, I hand over the mic back again to Dr. Bindia to continue with the program.
Thank you, Dr. Aruna, and indeed very wise words. So now I hand it over to Dr. Munisha. She is the master of ceremony today. So Dr. Munisha, over to you. Please conduct today's evening meeting.
Thank you, ma'am. And good evening, everyone. I think we'll start today's topic. I'll invite Dr. Pratima Raj. She's speakers for today's topic, that is CIN in pregnancy. Dr. Pratima Raj currently working as a consultant in gyneco in Manipal, Bangalore. I welcome you, ma'am. And along with Dr. Pratima, for today's session's chairpersons are Dr. Rupinder Shekhu, ma'am. She is chairman and HOD Gyneco Department and Robotic Surgery, Apollo Hospital, Delhi. I welcome you, ma'am. And I welcome Dr. Pallavi Ram, ma'am. She is currently professor in Gyneco Department, Kidwai, Bangalore. I welcome you, ma'am. Now I'll hand over it to Dr. Pratima Raj. Dr. Pratima? Hello? Dr. Pratima? Can you hear?
Please unmute yourself, Dr. Pratima. Dr. Anand, please help Dr. Pratima. I think she's not able to unmute hers.
Let me check now. Dr. Pratima, can you hear us? You have to unmute the mic. Dr. Pratima, you're muted. You have to click on the, or if you're unable to unmute, then you can leave the meeting and again join. Sometimes it gets hanged. So you can leave the Zoom meeting and again join. Dr. Pratima, can you hear us? I can see that you can hear, but you're muted, madam. You can leave the Zoom meeting and again join.
Dr. Monisha, you can ring her also.
Yeah, I'll just do that.
Shall I remove Dr. Pratima, then she can again join?
Yes, please.
Yeah, please do that.
Not allowing that also.
So in case there is a delay, and I think Dr. Premlata is here. So in case we'll just wait for 5 minutes. In case she's not able to join, then maybe we can start the panel, Dr. Aruna.
We will do that
But if someone
without
can call
wasting
Dr.
any
Pratima and
time.
guide her. She just has to try again. Tell you.
Shall we start with the panel first?
Yes, ma'am.
Yeah, please.
If you have the panelists, we can start with the panelists with the panel discussion first.
If panelists are available, I'll just start with the panel discussion. Today's panel discussion is CIN in special population. I'll welcome Dr. Annapurna ma'am. She is HOD and Senior Consultant Gynec-Onco Department, SSC Bengaluru. Dr. Jayashree ma'am, she is Professor in Gynec-Onco Department in Adyar Cancer Institute. Dr. Shweta Rai ma'am, she is Consultant Gynec-Onco in Medanta, Patna. Dr. Meenakshi Sharma ma'am, she is Senior Consultant Max Hospital, Patparganj, Delhi. Dr. B. Kalpana, Professor and HOD, OBG Medicity Institute of Medical Sciences, Hyderabad. Dr. Dhanand Dinesh, Assistant Professor Gynec-Onco in RCC Trivandrum. And today's expert for the panel discussions are Dr. Bhagyalakshmi ma'am. She is Senior Consultant and Professor Gynec-Onco RCC Cuttack. And Dr. Sundari ma'am. She is ex-professor Ramaya Hospital, Bengaluru. And today's moderator for the session is Dr. Premlata ma'am. She is HOD Gynec-Onco in St. John's Hospital, Bengaluru. And Dr. Shobha, she is Professor and HOD Kidwai, Bengaluru. I welcome you all, ma'am.
Good evening. Dr. Shobha. So can we start sharing the screen?
Good evening, all of you.
Good evening.
Good evening,
Good
ma'am.
evening, madam.
Good evening, ma'am.
Ma'am, you can share the screen.
Good evening, ma'am.
Good evening.
One second. Dr. Shobha is here.
Yes.
Yes, I'm here.
Will you start sharing, Shobha? First case, will you start or you want me to start?
I thought the first one was talk, no? Panel only, yeah?
Ma'am, somehow Dr. Pratima is unable to join. So that is why we are starting. There's some problem with the connection.
Okay. I think you start, Prema. I'll share. I'll just... I'm not able to open my desktop. You start. I'll start.
1 second. I'm out.
So it's
I think they should
challenging
share
evening for
the
everyone.
joining thing Zoom in mail instead of WhatsApp. It'll be easy for us to open the desktop.
Good evening, one and all. I welcome all the experts as well as the panelists. All the panelists and experts are already introduced. So the topic today is in CIN in special population. Are you able to hear me?
Yes.
Yes.
Yes, ma'am. Ma'am, please.
Can hear you.
Yes, ma'am.
So as we know, most of the guidelines, they apply to the average risk individual who has an intact cervix. So the CIN in special population mainly think I could get a reference from the ACCP. So if you see, most of the data has come for the KPNCC and the additional data, which is all for 25 to 65 years with average risk. So who comprises this special population? Oh, the special population includes younger than 25 years, pregnant women, immunosuppressed, post-hysterectomy, and older than 65 years. Let us, I think we have shared such that we are discussing younger than 25, immunosuppressed, post-hysterectomy, and older than 65 years. Since the pregnant topic is already being will be discussed by Dr. Pratima, we will not cover the cases on that, and we don't have much cases on pregnancy also. To start with the first case, she is a 58-year-old multiparous woman, post-hysterectomy done 1 year ago. The pre-op diagnosis as well as the PAP or HPR reports were not available. And she came with a history of vaginal burning sensation. And the local examination revealed that there was inflammation of the vagina, vulva, as well as the, periurethral structures, but no significant discharge. The perineum was normal. So here, now, should we take a LBC in this case, or how is it? So I will just start 1 second. Just give me 1 minute. I will just open the panelist's name. So we will start with Dr. Annapurna. So what are such a patient has come, what do you want to do? Do you want to take a cytology in her? Or just give some highlight on what are the screening guidelines post-hysterectomy? What do you do?
So first, whenever patient comes to the OPD and then says that it is post-hysterectomy, she has undergone a hysterectomy, then I would like to know what is a histopathology. And then I surely would want to know what is the state of the cervix if hysterectomy, complete hysterectomy, total hysterectomy has been done. So if histopathology is available, fine, and then it is cervix is fine, then we don't need to take a pap smear or any LBC in those kind of situations where that cervix has been completely removed and cervix is non-cancerous or non-pre-malignant CIN2 or above. If in case if the patient is unaware or not sure of it, then yes, I would surely want to do once to see as to what is the report that is there.
Okay. Suppose she was a previously treated patient of CIN2 and above, how would you?
So if it is a previous history or past history of any of the pre-invasive lesions of cervix are present that the patient is giving us, then we would like to follow her up at least for 25 years since last screening that she has undergone.
Okay. So our next thing is, so what will be the modality of screening? Do you want to do HPV testing or do you want to take a cytology? Dr. Danya, what are your practices, Danya?
Ma'am, I would prefer both cytology and HPV testing because cytology in this situation may not be very sensitive or having a good detection. So I would prefer to do a co-testing, both HPV and cytology.
Anybody has any opinion on this? How do you all go about, the rest of the panelists?
So as per all the HPV tests, they are all validated only for, I think, cervix. I'm not sure for vagina.
Yeah.
Yeah, actually,
So I think
can
a
I?
proper examination under a good light source is again with a little acetic acid can also give us an idea about what is happening inside the vagina or at the vault. So that's also not a bad idea unless the vagina is very narrow or it's difficult to do. But I think that's feasibility. And as we know that HPV testing is not approved for vaginal samples, and moreover, after hysterectomy, the HPV rates have seen in studies that the HPV rates are actually very high. Maybe they are not they don't correlate with cancer, but the HPV test rates are high after hysterectomy.
Okay, so maybe in our hospital, generally we do a cytology testing. Of course, if they are many years post hysterectomy, we just do an vaginal examination and may not do anything as such. But of course, if the histopathology is not known, and definitely if she's a high risk population, definitely a screening is required.
Somewhat different practice generally. I mean, for this aspect, I differ slightly because I will prefer doing HPV DNA testing here. That thing is there that HPV DNA sample is not validated for self-sampling vaginal samples, and it is validated for provider samples. But I'm not aware of any such aspect that we can't take a HPV DNA test post hysterectomy, because quite often we are doing it in post hysterectomy settings for CIN 2-3 on follow-up. So this thing is a bit new to me, that HPV test is not approved as for post hysterectomy setting, and having the accurate known that it is more accurate than.
Yes, only thing is what they had mentioned, it is not FDA approved, but definitely it is a sensitive test and it's a good modality of
Yes,
picking
we all
up.
use it. We all use
You
it.
use it.
We know it's not
Okay.
validated.
Okay, fine. We will move on. And now we have taken a LBC sample which has shown as HSIL. So what next in this case? Yeah, Dr. Meenakshi?
Yes, if the LBC comes L cell, then we can just observe the patient, especially if we have already done a co-testing, and if the HPV is negative and it is just L cell, we can just observe. But if it comes to be a H cell and an HPV positive, we would like to excise the lesion. Like an apical partial vaginectomy can be done
No,
in a
before that
post-hysterectomy
exercise,
patient.
how would you like to examine the vagina? How would you like to examine the vagina?
We would like to examine under a microscope. We will be doing a colposcopy and doing a visual inspection before applying an acetic acid and after applying an acetic acid, and especially for doing a vaginal examination, we need to have a concentration of 5% acetic acid. And then we look for any visible lesion. And if any visible lesion is seen, we should be excising it. If it's a small lesion, we can excise it completely and send it for histopathology.
I will just come with that part. First, could you just, you have already elaborated on how you would like to do colposcopy of the vagina. Um, so, will you generally use a cusco speculum, or is it visible all over when you see? Because vagina, if you just hold on both cervix, anterior vagina, posterior vagina is all mixed. Definitely, how would you really step by step do the procedure of a vaginal colposcopy?
Basically, we'll be applying the Cusco speculum and we'll be rotating it 360 degrees so that we can inspect whole of the vagina as far as possible. And if it is the apex of the vagina is there is a deep earring, then it becomes little difficult for doing a colposcopy. And if it is not possible to rotate and see all the vaginal mucosa because of the rugosity of the vagina, then we can even do a small, vaginoscopy using a hysteroscope and instilling the vagina, the line and distending the vaginal cavity, and sometimes it comes out very beautifully.
Okay. Fine. So the important part is,
to use some transparent speculums, so that this steel cuscos does obscure sometimes some of the
Yes.
views. So a transparent speculum sometimes can help you see better.
Yes, if it is available, then it will be better, but usually it's not available. What we have is the cuscos, long bladed ones, which we can rotate it easily in all the directions. Usually, we are able to see the all the parts of the vagina.
Fine. I think we have completed. Can anybody? So this is what we have done a vaginoscopy, and these are the findings. Of course, I think since we have seen it on our own, it is easy. But here for the panelist, it is just an image. I don't know how far, but can Dr. Shweta, can you just comment on what you can see here?
Yes, so it is quite evident here that there is a lot of vastovightening involving the whole of the vagina, periurethral area. Maybe it is going inside the meatus also, and somewhat in the perineal area, in the posterior vulva, and maybe it is extending to the still posteriorly. So it is appearing as quite high risk lesion, and I do have a suspicion that there might be some invasive component. Might be.
Yes, it just looks like that. Of course, see this patient who had a hysterectomy 1 year back, and within a short duration, with just 1 year, we are seeing such a wide lesion. So probably This could have been a CIN lesion which was not missed, which they have done a hysterectomy, no biopsy report available. Probably there could have been a cervical lesion also. So I would like to introduce the concept of the newer concept that is called the multizonal intraepithelial neoplasia. So Dr. One second. Dr. Kalpana, could you just elaborate on what is this multizonal intraepithelial neoplasia?
Yeah. So usually this multizonal intraepithelial neoplasia refers to the presence of intraepithelial neoplastic lesions in two or more anatomical sites of the lower genital tract and or anus. So usually the cervix, the vulva, vagina, the cervix and the anal or areas are involved. And usually it is suggested that persistent high-risk HPV infection is the cause, especially the HPV 16. And then usually we have again two categories, like it can be synchronous or it is usually the synchronous is usually the multiple sites are involved because of the persistent HPV infection. And then the metachronous is that the different sites are involved at different time points, usually after 12 months. And usually the risk factors for these include usually women who are immunocompromised, who are smokers, or who had prior cervical or vulval neoplasia. So that's the reason why actually we need a comprehensive evaluation of all the areas, the cervix, the vagina, the vulva, and the anal region. Yeah.
Okay, so this particular image which you could see here, this is in fact, we had treated it a few years ago, maybe around 2019. This was a case of retropositive patient. She did have a cervical as well as vaginal biopsy we had not taken, but the entire vulva, perineum, perianal, and even posterior natal cleft. The natal cleft was in fact a squamous cell carcinoma. So this is a classic thing how of immunosuppressive patient can present with multi-site disease, and the importance of screening the entire vulva, perineum, perianal region in these high-risk population. So coming to our case.
Premlata, was this a case of HIV or
this was a HIV patient. Yes, yes, she was a HIV positive patient who was on treatment.
Did you give her RT? What did you do? Because operating her might have been a real means. Did you operate this?
Yes, we have operated this case. In fact, because the perianal region, it was mainly the rest of them were HSIL lesions and warty lesions. Only the perianal part was the malignant part. So that was completely excised and a plastic repair was done. Of course, she had CIN 3 lesions of the cervix. We had done a hysterectomy also for her. And this entire skinning vulvectomy, I had an image of how it looked post surgery, but I have not, it is all in my mail. The entire lesion had disappeared, but we had done a skin graft. The peculiarly what was seen is grafted skin never recurred, but whatever the ungrafted skin, the warty lesion had come back after the next follow-up we could see to say that the genital area that has a predisposition for HPV, the grafted area which was taken from the thigh never had the lesion, but peculiarly only the genital area where the graft was not done recurred back with the warty lesion. So telling that the HPV has a predilection mainly for the anogenital area. Okay. So moving on with our case, sorry, I had to go back and forth. So post that, how would you like to manage the case of this vaginal intraepithelial neoplasia? We have done a colposcopy. Now, how would you like to manage? Before management, one needs to know how to properly report a colposcopy of the vagina. Almost it is, Dr. Jayashree, would you like to explain
Yeah,
this?
ma'am, I'm here. Can you hear me?
Yeah.
Yeah, and as ma'am said rightly, that examining the patient and documenting a post-hysterectomy or a patient who has not undergone hysterectomy for the findings is very essential. And as the teaching goes, document with the terminology of 2011, and to add on, we can use read score or read score. And add on to that, the third pattern, the pictorial pattern. If you club all three, like terminology wise and the scoring wise and the pictorial wise, the documentation never goes wrong and it helps the subsequent person, whoever is seeing the patient, to correctly catch where was the lesion and how was the lesion. And I prefer IFCPC terminology because it's very simple and the words are already there. The chance of missing out is very less. And it's even better than the speech and read score because all the terminologies, whatever we may have to remember, are all are there. Speech and read score gives a numerical terminology when the terminology from IFCPC gives a complete picture. Like you have a grade 1 minor, grade 2 major lesions, based on the astrocyte areas, punctations, and mosaics, and it gives all the suspicious of invasion features also, and additional signs, whatever we see, and the non-specific findings, and all of them are there in the form. So if we club them like IFCPC 2011 with the picture of the pictorial imaging, maybe Odals or Hamleys, with a speech score or read score, becomes a complete documentation for colposcopy, and it help us definitely when we're going for a treatment. If the person who's doing colposcopy is different from the person who's treating also, this kind of documentation helps completely.
Yeah, thank you. And importantly, we need to mention, as she said, which upper third, lower third, or anterior, posterior, because this helps in the management of how we proceed for the management. So, Dr. Shweta, would you like to elaborate on the management of these? How would you like to manage this case?
Yeah, so it all depends on it depends on two, three factors. So one very important thing is what is the appearance of the lesion when we are doing the colposcopy, like how big is the lesion, how much suspicion of invasion we have. Apart from that, we also need to know if the patient has had any previous treatment, previous excision. Also, we need to know whether it is whether the lesion is unifocal, multifocal. These are all the aspects which we need to take into account when deciding the further treatment. Ideally, when the lesion is small, accessible, the best treatment is just excise it off. However, quite often the lesion is either multifocal or the lesion is quite extensive. In that case, the treatments may vary. Excision may not be the best option in those cases. Then we do have other treatments like ablative treatments. Also, sometimes for VAIN3 brachy may be considered in case all other options are not there. Yeah, those are the things, and then there are other things like immunomodulators, like imiquimod and other things that may be considered on case basis as to how much is the extent of the lesion.
Yes. So as Dr. Shweta explained, maybe I think the better mode will be a surgery especially if it's upper vagina and there will be dog ears, which is post hysterectomy, which even the local therapy may not act if you put a IFU or MICMO. So upper vaginectomy is a better option, but of course total vaginectomy is quite a radical procedure, and especially if she's a young patient. So you can combine vaginectomy with the laser vaporization, it is available, or a mode. A combination of treatment can also be tried. So this is another case which we had, if you can see, in 2024. She is also post hysterectomy for CIN3. She had a complete, you could see the lesions here, but this is the post mode. In fact, it has not regret, it has increased here. So we have suggested her a total vaginectomy because the entire vagina is involved in this case also. So yet not done. So with this, I think we have almost covered most of the vein treatment. The experts want to give a comment, Dr. Sundari or Dr. Bhagyalakshmi? If not, I think we will conclude this case, and Dr. Shobha, will you take over the next case?
Yeah. So only in young patients who are HPV positive, can you hear me?
Yes, ma'am.
Yes, ma'am.
So more recently, there are so many types of local applications which are now coming up in the market, though we really don't have any authenticity about their use, or maybe we are not very sure whether they work or not. But more recently, I think in the ESGO conference, they were actually showcasing a gel called Papillocare, which is actually when there is human papillomavirus associated CIN, we can can use this on the treatment continues for a long time. It's a combination of, I think, aloe vera, hyaluronic acid, and some herbal treatments also are ingredients of that. So those things are actually coming up in the market too much. So I think for an experimental method, we may try it, but I think we still need some evidence for that.
Okay, yeah.
Ma'am, your opinion on how to use this drugs, ma'am? Like when we say the patients to apply specifically on the area of lesion and the amount, it becomes very difficult unless we call them for
No, I think in
application.
vulva we can do that. In the vulva, actually, most of the time I tell them to come to the clinic.
Ma'am.
Yeah.
As when we're coming to vaginal
So
lesions and
I think
even
vulva is
vulval
different
lesions
in
and vagina becomes very difficult because the patient gets a severe burning when they apply it in more
Yes,
areas and
yes.
they come back to us.
We had one patient whom we treated with hemicumoid. She was post-hysterectomy done after she was HPV positive outside, and then it was found to be CIN3, and then in post like follow-up setting, she came to be HPV positive and then VIN3. So we did a biopsy, it was VIN3, and we treated her with hemicumoid. We used to call her every like thrice a week, and she used to come. I was a bit skeptical about whether she will come, but then she followed for 16 weeks. We did treat, and follow up is like follow up. The thing was good, like it resolved. I'm not sure what will be the long term outcome. She is yet to be.
Yeah, actually they need a lot of counseling and motivation.
But somehow we have
we
4 cases which are still persisting, not disappearing, and the radiation oncologist hesitate to give brachytherapy. So, what are your opinions on brachytherapy?
And brachytherapy, I think we can give if the lesion is quite extensive and the HPR is VIN3, because then it leads to a lot of anxiety if we are not treating.
Yes.
If we are treating, the other modalities are going to cause her a lot of morbidities. Even if we excise, even if we ablate, whatever we do, all other modalities are going to give her a lot of side effects considering the extensiveness. So if it is like the whole vaginal length involved or multifocal, something like that, and it is sure shot VIN3, I will suggest
Yes, I think Vidya
this
very
for breaking.
rightly
Madam,
pointed
even
out.
I had one case, madam, which was aplastic anemia on immunosuppressant. And she had extensive, young lady and extensive vulval, vaginal, perianal mets, warts. And ultimately, I could never take her up, and it was so big and
Mets
causing a
or
lot of
warts,
problems.
Annapurna?
Pardon, ma'am? Hello?
Hello. Yeah, Shobha.
Yes.
Shobha, you're ready, Shobha?
Hello.
Yeah.
Yeah. I thought Anpurna was asking something. She was not
No, no. I was just wanting to tell that as
Okay.
madam was telling herbal, so I
Okay.
had to refer to homeo people for this. And because I could not put a knife also on her huge, huge vulval mets and vulval warts, not mets, sorry. So,
Warts.
and it regressed. And 1 month she had had fantastic response. I don't know what was used there.
Herbal treatment, huh?
Yes.
Okay. So, good evening, everyone. Thanks to Dr. Pratima and team for inviting me for this forum. And it's a kind of a learning session for me, more than, teaching and moderating. So, I have all the panel experts who are sitting here. So, this reason, I could read something which is out of my syllabus and what we see very less in our practice. So definitely it's very helpful to me, and hopefully I can take more points from my experts. Yeah, so today I'll be presenting a postmenopausal lady more than 65 years, how we go about, and then adolescent that is less than 25 years.
Shobha, could you make it full screen?
Yes. And it's like after looking at Prema's, more very colorful slides. Mine is like dal sambar. So
Black and white movie.
hopefully, I think all your discussions will make it colorful. So I have a grand lady coming in, walking into my OPD with her granddaughter because she heard about the vaccine. So she's come for vaccination for her granddaughter, and then she casually asked, "I have not got any test done. So do you recommend me to undergo this any test against this cancer. So how will you counsel her? She's a 70-year-old, walked along with her granddaughter into the OPD. So what kind of counseling is required?
Shubha ma'am, similar kind of situation I had a program in FM Rainbow.
Yeah,
And
Jayashree,
then,
you can answer.
yeah, it's me.
Perfect.
So exactly 70 years old. I
Ah.
was talking about vaccination and screening for the general population in the screening age group. And a 70 years old called her from a triplicate in a local place. And she asked me, like, I never undergone a screening. What about me? And it was so tricky that I told her, like, I mean, the guidelines are all for those Western world where they have a regular screening from the age of 21 years. So even for those who are undergoing a screening after 30 years. So if a lady hasn't undergone a screening in a lifetime and if she's willing to go for a screening, at least she deserves a speculum examination. At least a speculum examination. We should not deny her examination.
Yes.
I think I will offer her at least one sitting of
Screening at least.
Yes,
Screening
at least one, and preferably with HPV DNA test.
The 65 cutoff is for those who already are in regular screening, and they even say that to continue screening if they have a problem. For a population like ours, where they haven't undergone any screening in their lifetime, and when they hit us by chance, I think we should take it as an opportunity to screen her, than denying her a chance of getting a screening.
Yes.
Jeshu very much agreed with you. But I think this fag end, they're not ready for any kind of screening. So counseling them will actually be a Herculean task. So they'll actually
She's
come for the
herself
vaccination.
asking.
But if you
She's
suggest
herself.
also, you have to put a lot of effort to get them screened.
That's what those who volunteer to come and get screened, I feel we shouldn't say that 70 is not the age to get screened, 65 is the cutoff, and we
Fine,
want
then
to
it's
do
fine.
Herself asking.
Yeah.
Yes.
Yeah, same thing. Can I say? Yes,
Yes,
we do
please.
population-based screening in Chikbadapur district here near Bangalore. And 70-year-old women, always they come there. And we are doing regularly screening for them with HPV DNA. Because they never had screening in their lifetime. But somehow, when they come with the other group of people, for each village we do, other people, they agree to get the screening done and we are able to do it. And one or two cases I had positive cases also. And LSIL is common. I think if you take a pap smear, LSIL and ascus are very common in postmenopausal women. We have been seeing it. But HPV DNA also one or two cases came positive and I did a colposcopy for them. So at 70 also routinely we are doing because these women will not undergo any screening in their lifetime. Villages.
Doing a cytology is something very, I think, because moms, lot of ascus being
Lot of
reported
changes,
and
yes.
unnecessary with the parabasal and these atrophic cells, ascus being reported will be very high and unnecessary. We follow up with the additional tests. Maybe once HPV testing might be a better option. Yeah.
Yes. Usually it gives ascus. Initially they used to say LSIL before epithets came. And now they say ascus. Most of the women pap smears will say postmenopausal women. Even they may not be not 70, but even 50, 60 if they are postmenopausal. I've seen the smears being reported as ascus.
Yes.
And
So I
LSIL
think
also.
the question has ignited the whole of the panel, and I had all of them answer to that. Very nice. So
Can
first
I
we
add one thing?
acknowledge her coming forward and asking us, and then clarify her intent. What is her intent? Whether she needs definitely needs something to be done. She wants to get screened, or whether we have to clarify any symptoms other which is like hesitant or shy to tell. Maybe she might be having some white discharge or some white kind of post-menopausal spotting or something. Clarify if no symptoms are there or what. And then, even though routine recommendation stops at 65, but that says provided if adequately screened previously and no major abnormalities are there, then we can stop. So now, considering her, no screening at all, no examination at all, definitely she's at high risk. We have to consider her like that and then screen her. Indication is definitely there. You can screen her. So as you all said, that screening method, yes, HPV DNA preferred, definitely you can offer her. And then cytology, pap smear otherwise. Co-testing, as again, you already answered this, but you can still put in more points. What are the difficulties in interpretation of pap smear in this age group? Already Prema put one or two points.
Getting inadequate cells in the atrophic vagina. That is the most important difficult. Then sometimes these atrophic cells appear somewhat this plastic, and then reporting of ascars and beyond lesions, which later on, if we tell them to apply estrogen, they will come as normal. So these are all the struggles that unnecessarily increases her anxiety. So
Yes.
it's
So
better that
parabenzyl cells
Don't
are
get
there. Yeah, inflammation is there. So
TZ won't be there, so endocervic cells and all everything is drawn inside atrophic.
yeah,
So you won't get a proper smear.
and atrophic sometimes can mimic head cell. So it can be, put it as a high grade abnormality. So recalling will be there. So then pap smear, HPV is definitely better. But co-testing, if you take both, you can definitely do. So as I said,
Probably, if we apply saline and leave it for 2 minutes and take a smear, you get the
I think
cells. You
you
get the
can.
cells. I do that. Atrophic, when they come with the postmenopausal and you see the atrophic, you don't get any scraping, you will not be able to get. So what I do is apply saline for some time and moisten the cervix and then take a smear. Probably you will get some yield of cells.
But
Because of
atrophic is
the
due to hypoestrogenic state, madam, not due
yeah,
to the
because of the
dryness.
estrogenic state,
Yeah.
hypoestrogenic cells look as she said, no, Sweta said, it looks like it is plastic cells. That is very common.
So usually you either give them a short course of estrogen and
No,
follow
I
that
do
up
the
to 2
saline.
weeks.
Yeah, that also is recommended.
So yeah, this also I think we answered that. So cytology alone is unreliable in these, more of false positive because of atrophic lesions, but it could be false negative also because of poor cellularity. HPV testing will add the sensitivity, so that is less affected by atrophy. So definitely with HPV we can help the over treatment. We can stop, reduce the over treatment, or guide accordingly whatever is optimal for her. So next pap smear comes abnormal. What do you want to do? Abnormal, it could be LCL or HCL. Do you want to take her up directly for colposcopy or?
Yeah, sure. But colposcopy at 70 will be really difficult because the whole of the transformation zone has gone inside.
Yes.
And the service is so flushed, we may not, it may be a little, only a small opening, only maybe sometimes.
I don't think so many of us get any added points with colposcopy for us to take it as high grade or invasive or this one. So colposcopy in these cases are definitely very, very difficult for us. So we just see like this, and even the astro-white uptake is not very uniform, not very dense. Because sometimes the vasculature here, it might appear some kind of atypical changes which might not be there, or when atypical changes are there, which might be masked. It can be both scenarios might be there. So it does not correlate here as we younger or little like 50 plus postmenopausal age group people. When we do, the changes might be a little better with the colposcopy, unlike in this case. So here, because
if it is a low-grade lesion, Shobha, we can just observe them because colposcopy is not very satisfactory and adequate in them. But if it comes as HSIL, probably one thing is attempt to do colpo. Otherwise, we can do ECC and then see whether we can get some material.
With the co-testing, HPV is positive and it is LCL.
HPV is positive, definitely we have to do.
So both
Definitely we have to do HSIL if it is HSIL. If it is low-grade lesions,
somebody's
probably
audio
we
is
can
on.
wait.
Could you please ask them to
Yeah,
mute?
please,
Can
Dr.
anyone
Renu
please
Yadav,
mute
please
those who are not
mute
connected?
yourself. It's very disturbing.
Yeah, thank you. So also because of fragile epithelium, it bleeds easily. So whenever we just apply acetic acid, it might just start bleeding, obscures the vision. So difficult to take biopsy, hold the thing in tissues, and it's very difficult to take biopsy. And because of narrow os, utilization of endocervical canal is also difficult, and sampling also is difficult here. So now we have unsatisfactory.
1 minute. Dr. Renu Yadav, please mute yourself. It is very disturbing. Sorry, ma'am. Continue, please.
Yeah. So your colposcopy shows grade 2 changes, but it is extending into the endocervix. Abnormal, some vasculature kind is seen. You can't make out whether it is coarse punctation or something. As I showed you there, there's some prominent vasculature is there. So what next? How will you proceed?
Diagnostic excisional procedure in this case.
Yeah, so there's no doubt at all. So excisional procedure, you can take a direct decision of doing an excisional procedure. So you want to do with a leap or do you want to do a conization?
Many a time we find it very difficult because
Very
they'll all
difficult.
be,
That's
madam said,
exactly
no?
what I was trying to say.
All
Because leap is also difficult, excision is also difficult.
Yes, very tough. Can't hold the cervix only sometimes. It's
Yeah.
completely
We have
flushed
to
and
be
it's
very,
so
very
small, it
careful.
will be atrophic.
Ma'am, these are the rare cases where we do sometimes offer hysterectomy if we can't do anything else.
There is nothing before that. We can do a bit of hysteroscopy. So
Madam,
I think
you can't hysteroscopy. You
yeah.
can't even hold the cervix. You're saying how will you do hysteroscopy?
No, the other
very tough.
hysteroscopes where you don't need to hold the cervix at all. So do the vaginoscopy.
No, definitely.
Office
Definitely, we need to hold cervix
Hysteroscope.
at least to insert that even a 3 cannula. Definitely, we need to hold the anterior lip of cervix. Very difficult just to manipulate like that. And these are very thin and it's not very sturdy. Like
So the ones with the do in the vaginoscopy and go into the cervix without with a little dilatation, I think maybe you could get some evidence because I don't know. In my experience, cone in such 70 years is really difficult.
Yeah, very difficult. So whatever,
I can't.
I read also, there's no mention of hysteroscope anywhere. So it is just like you try to do a leap or lets. So excisional procedure is maybe, it might not be curative itself. So you need a diagnosis. So even if it comes as CIN3, then depending on the adequacy of the tissue, you're going to decide whether you have to go for type of radicality, whether simple hysterectomy is enough or you'll have to do a radical hysterectomy. So that again depends on all other factors also, which we will discuss. So here, the one point I want to mention is that about 15 to 20% of it, we can miss out invasion here, especially in this kind. So is there a role of any imaging here before you do this? So, your pap has come head seal, your colposcopy, some kind of abnormality is there and your HPV is positive. Higher imaging, will it help in any way? Do you want to do? Because the basic ultrasound we would have done. So, MRI, before posting her for colposcopy, do we need to send her for an MRI?
Not always. If generally the diagnostic excisional procedure will let us know if the lesion is intraepithelial or it is invasive. Mostly it will tell, and therefore we don't need. In some cases, when the patient just refuses to have diagnostic excisional, and sometimes she will request only CIN3, and then you please do something one step and for all. In those cases, if we are forced to do something like hysterectomy, I will prefer to do a MRI to see if there is anything obvious in the cervix and which will entail me doing somewhat more radical procedure.
Yeah, if the cytology is suspicious,
Clinically,
do that.
Dr.
If the cytology shows some malignant cells or something, you can do that. But I think
patient doesn't have any symptoms, like patient is
otherwise
having,
not.
If patient doesn't have any symptoms and if clinically cervix feels very atrophic, doesn't even have any volume in that, I don't think MRI is going to add to any data further to our colposcopy. Obviously, the patient is symptomatic and clinical suspicion of endocervical growth is there. Then we will proceed with imaging based on that, not based on our findings or Excel on the pap smear.
But here is a patient who is not screened at all. Once also only for her, pregnancy and delivery, she has gone many years back. So we don't know if it is receded inside. So any abnormality in the endocervix, do you want to see or not? Even if it's obvious growth,
you can use an endocervical speculum. If you are not happy with doing a hysteroscope and looking at an endocervical canal, you can still use an endocervical speculum and visualize the endocervix.
In this case, what
clinically,
I feel is
use a bit of misoprostol.
Yeah,
the cervix becomes a little soft.
I think that might help us at least. Allow her to action of misoprostol and then take her up for colposcopy. Maybe this endocervical visualization and all will become slightly better, or even the as you told, hysteroscopy insertion may be slightly better here.
Clinically, if cervix is hard, also I would like to do something to see whether it is anything more than head seal or L seal, whatever we are getting.
Maybe little bulky cervix or ballooned out
Symptomatology and examination findings, other than our pap and colpo, guides us a lot more towards what should we do. than segmentizing the reports, like just discussing it as HCL and smear. If you go on with complete picture, then we'll be having a fair idea where to go.
The head cell, when you have ruled out it is not an atropic changes, it's a proper head cell, then having a high grade lesion or microinvasive cancer is slightly high in this age group. Where, right?
Even then, MRI is not, if it is microinvasive also, MRI is not going to help us in identifying the lesion.
Not pick up.
It's not going to pick up unless there is a gross lesion.
Yes.
Then MRI is not going to pick up. And in that case, when there is a gross lesion, usually cervix obeys to the gynecologist, allows some instruments inside and allows endocervical brush, either brush or speculum. Because it's dilated and it's soft and stroma is weakened. So usually it allows. If it is adamant thin, usually it is normal.
Sorry to interrupt
So
in
this is
between. I think we have only 5 minutes left for the panel
That's
discussion.
all. Oh, okay, fine.
Yeah. And then we have to go for Dr. Pratima.
But sometimes it happens that we are unable to see the cervix itself will not be seen. I mean, because of adhesions or nothing. So it will be completely closed. Then it becomes very difficult.
Yeah. I think, see, our practice usually is that, yes, depending on the patient, we ask in depth about what kind of symptoms she has. She might be having some kind of pain, which she might not share it. But then when we ask her, she might say, yes, some discomfort is there in the pelvis. So that might be there some kind of endocervical collection or, irregularity or this one. So MRI, we do sometimes do when pap smear is showing head cell. And then with colposcopy, if we need to do a leap only, so that might be just a diagnostic. So either it might be CIN3 or it might come as microinvasive or suspicious of malignancy. So whatever we get, so we will then, depending with the, because after leap, if you go to do MRI, it might get, the findings might not be accurate. So if we suspect, yes, she might have some kind of microinvasive or early cancer, definitely MRI first we advise, and then going for colposcopy guided procedure. So that even if we have to do a radical, even though biopsy has come as suspicious of malignancy or microinvasive, cannot be ruled out, then we'll go on to do a radical hysterectomy. So is with the microinvasion, is simple hysterectomy enough, or conization is enough in this case? Like, 70-year-old, just a conization you do, and if it comes as microinvasive, margins negative.
I will personally not be okay with just conization. Having said that, the evidence is emerging, but at present, I'm not comfortable going just with conization with a diagnosis of microinvasion. I will plan her for type 2 radical at least.
Oh, okay. Even with microinvasion, you don't want to know the depth of the invasion?
Yeah, okay.
Yeah, if it's 1A1, you don't have to go ahead, maybe.
Yes.
Right? 1A2, yes.
Even with 1A1, at least I will counsel for hysterectomy, because I'm not very comfortable. Even if we have evidences from all the recent trials that have come, I personally think right now we are not in a position to safely not offer a hysterectomy after microinvasive diagnosis. So if it is 1A1, maybe a simple hysterectomy, 1A2, type 2, something like that, I will offer her after this diagnosis.
So also consider her expected life and quality of life. Her
That
morbidity,
always is there, but she's 70 years, so and in that case, no comorbidities, definitely will offer.
Okay, I think we will, because there's I think shortage of time. So now coming to younger adolescents, less than 25. So our screening starts from 25. So why is it considered special here? Why do we have to put them under the category of special? Why not? Because we know all the kids are now sexually active from the age of 15 itself. So why not bring down the screening age to 18 or 20? Why is it? One group has said 21 years. Okay, but most of them recommend from the age of 25.
They clear the virus very fast. So they have less number. The risk of having CIN in this population is very less. So that's why majority of the guidelines have taken 25 onwards.
Unnecessary HPV positivity, which will unnecessarily create tensions.
Yeah. So once they start
all transient infections, yes.
Yeah, after the sexual debut, the HPV acquisition is very, very high. but the clearance rates are equally high also. So even if you do a screening test in this age group, there's a discordance between the cytology and HPV is very common here. So the overtreatment is high, which might affect the fertility further. So observation is the best here. So we do give most of the guidelines says from the age of 25 is a adequate. So what is the regression pattern here? Persistence of HPV in this age group, less than 25 years. Is it similar to the adult age group or?
Yes.
So 80% is likely,
Much
more
less,
than
no?
80% is likely to clear by 2 years of age in this age group.
90%, they say within 1 or 2 years it comes back to normal. Persistence is up to 10%, and maybe with the people with sexual behavioral codes and all, persistence will be there up to 20%. So even beyond 2 years. So progression to invasion is only less than 1%. So definitely the invasion is less. So we have to think more of conservative here, as fertility is definitely to be kept in mind. So if, yeah, sorry. So I think 1 or 2 case, just I'll ask and you can answer and then we can stop this. So 20-year-old who is sexually active, she did a self-HPV test and then that is showing LCIL, HPV is positive. Now, what you want to do next? You want to go ahead with colposcopy and guided things, or you want to say her do genotyping, see which HPV is positive, 16 or 18? What do you want to do for her?
Maybe I will repeat the
Yes, I think that's the only way out. We have to say which is the HPV which is positive.
So genotyping
and plan accordingly.
Important.
So because they have studies have shown that 16 and 18, especially 18, the persistence of 18 is very high in this age group. So I think that will help us to keep her a close surveillance or take her for colposcopy according to the. So what are the indications for colposcopy here then? When do you call her for colposcopy?
Only HCIL. HCIL or high grade lesions only. If it is there, then only we will be asking for colposcopy and again wait and watch.
Yeah. So most of the time, only whenever there is a high grade lesion or whenever there is a if persistent if she complains of postcoital bleeding is there or colposcopic changes are there high grade, so then you can definitely think as high.
Also, if she is immunocompromised and HIV, then
positive, yes.
And vaccination, I think giving her vaccination is more important.
Counseling regarding that also is very important here. So this, if now she's another 22-year-old CIN3 not vaccinated, biopsy CIN3. So what is the management you will do in her?
It's a tough decision, but I think I will go with, again, having counseled her for the implications, I will go with diagnostic excision in her case. Ablation is an option, but then the effect of ablation will almost be similar on the os, like causing stenosis of the os, and then we will not have the histopathology, final histopathology of the involved area. So I think I will go with diagnostic excisional and keep the excised area small.
HPV also, I would like to know.
CIN3 young. So this is the one which we all have to be clear. Other thing we can either wait and watch.
HPV also we need to know what is the HPV here. Is it 16 or other high risk HPVs or what is it? If it is other high risk, it can regress.
18
Then
positive.
16.
Sorry to interrupt. I think we are getting late and
okay.
Maybe. Thank my panelists, my moderators and experts for the panel. Thank you so much.
Okay,
thank you all. Thank you all.
Thank you
Nice
so
cases.
much. Thank you. These topics can go on for hours together.
Thank you so
Also,
much.
we'll find some other day to discuss more. And I'll invite Dr. Pratima Raj, today's speaker for CIN pregnancy. And I'll invite chairmen for the session. I welcome Dr. Rupendra Shekhu ma'am, who is chairman and HOD Gynec-Onco Department, Apollo Hospital, Delhi. And I'll welcome Dr. Pallavi Ram ma'am, who is professor Gynec-Onco Department in Kidwai, Bengaluru. And now it's all to you, Dr. Pratima. Please take over.
Thank you, Dr.
Good evening.
Manoj.
Am I audible?
Yes, Dr. Pratima.
Good evening, respected chairperson, dear faculty, and all my delegates. I thank Dr. Bindya Gupta and Dr. Aruna Nigam, President ISSCP, for giving me this opportunity to organize this event. Screen sharing, I'm not able to do. Ma'am,
Shobha,
The
you have
screen is already shared. It was the PowerPoint was not showing. Can you again share your
Share
screen?
now? Yeah, you can share, I think.
You can try sharing your screen, ma'am. Now.
I'll just try. Is it visible?
No, Dr. Pratima.
Not visible? Okay.
Dr. Anand can share your slides you've sent him.
Yes, ma'am.
Dr.
Share
Anand,
with me,
please
ma'am.
share the slides.
Pratima, you can say next and I'll go to
Yeah,
the.
I'm sharing. Is it visible?
Achha, you want to share? Just a second,
No,
I'll stop.
this is your screen or your screen,
Yeah,
sir?
my screen. It's my screen.
Okay, fine. Yeah, that's okay then.
Shall we go ahead like this? Is it
Yeah,
fine, Dr.
yeah, we can go ahead
You
with
can
this.
just say the next and I'll go to the next.
Yes. Okay, next. So we know it's. I'm audible, right? Yeah. Okay. So the burden of cervical cancer in 2023, India witnessed around 1,27,000 of new cervical cancer cases, and approximately half of them accounted to deaths. As per prediction models, a total of 22 lakhs women in India will die from the disease between 2020 and 2070, which will further rise to 27 lakhs by 2120. So the WHO proposed 90-70-90 target to be implemented by 2030, so that it would lead to the elimination of cervical cancer as a public health problem. Next. So, to achieve the WHO screening target, the idea of utilizing antenatal periods seems to be very practical. Most women in India go to an obstetrician for the first time when they are pregnant, so that we can catch the missed cases and early detection, so that we can treat them immediately. So these women are more receptive to medical advice and follow up during the antenatal period. Pregnant patients are considered as a special population because management and therapeutic options must weigh the potential risks to the patient women and fetus versus risk of a potential missed cancer diagnosis. Next. So why cervical cancer screening is important pregnancy? Because we see 5 to 10% incidence of abnormal cervical cytology during pregnancy, which is a direct precursor of cervical cancer that is usually detected and managed through pap smear or high risk HPV DNA testing. So incidence of cervical cancer during pregnancy varies from 3 to 26 per lakh live births. Next. What are the challenges we come across while screening in pregnancy? Pregnancy, we see that there is hormone-induced changes in the cervix, which leads to cervix hyperemia, frequent inflammation, excessive mucus production, hypervascularity, which leads to bleeding, which again further obscures proper visualization. There are area stellar reactions, cytotrophoblasts, intratrophoblasts, decidual cells, and immature metaplastic cells, which mimic atypical or high-grade intraepithelial lesion, which again causes challenges to the cytopathologists for interpretations, which leads to high false positive rate. Next. Pap smear should be the first line diagnostic tool during pregnancy, particularly LBC over the traditional smear test, because it gives accurate results and reduces the likelihood of insufficient samples. The technique for collecting cytology is same for pregnant and non-pregnant patients, and the broom is supposed to be safe and efficient tool, and which is recommended for obtaining cervical screening samples in pregnant women. Next. So there is no risk to the fetus. Spotting and miral bleeding can be there. Early second trimester is an ideal time as endocervical cells are translocated outside the cervix. The transformation zone is visualized easily and sampler is easier at this time. Next. So there was a meta-analysis published in 2023 of 144 studies, which shows that global prevalence of HPV in pregnancy is up to 30% in cervix and vagina. Given that pregnancy is a state of mild immunosuppressions and there is immunological adaptations, the manifestation of HPV may become more severe in pregnant women when compared to non-pregnant women. And hence there can be persistence of lesion during pregnancy. But in the postpartum period, when this adaptation weans off, again there is characterized by increase in HPV clearance, and then there is regression of these lesions. So HPV, next. So HPV test, next, previous slides, previous. HPV testing, DNA testing is increasingly preferred over cytology alone due to its higher sensitivity even during pregnancy, and it also helps in risk stratified management. If high risk HPV is detected in pregnancy, it warrants early colposcopy, while others can be triaged with cytology. Next. So what are the abnormal results after cytology? It can be ASCUS, LCIL, HCIL, ASCH, AIS, and abnormal glandular cells. After HPV testing, we can see HPV 16, 18, or other high-risk type of HPV can be detected. Next. So how to manage these abnormal results in pregnancy? For the management of abnormal pap smears, colposcopy with targeted biopsy and histological examination for dysplasia is a procedure of choice. Indication for colposcopic examination are similar for both pregnant and non-pregnant women. Next. Colposcopy examinations are more challenging in pregnancies due to the appearance of cervix that changes greatly throughout the pregnancy. On one hand, colposcopic evaluation is much easier to be performed because of the squamous-columnar junction, and TZ are better exposed due to the physiological erosion of the columnar epithelium, but visualization of all four quadrants is hindered by excessive secretions, edema, cyanosis, bleeding, vaginal wall protrusion, and mucus. Next. So, and hence the colposcopy in pregnancy has to be performed by a experienced colposcopist. If the findings of a colposcopic examination conducted any time during pregnancy are inconclusive, colposcopy should be repeated after the span of 6 to 12 weeks. Sometimes, if the transformation zone is not visible, we can use a ring forceps, which may be used in place of endocervical speculum to dilate the os and reach a complete visualization of the endocervical canal. If the TZ cannot be entirely visualized, the risk of complication associated with diagnostic conization should be balanced against the likelihood of having underlying malignancy. Next. So there was a study, and I've shown in this table, we can see that they have done a comparison between colposcopic findings at the time of pregnancy and after the histopathological findings at the same time, and they have seen the concordance. So the rate of overdiagnosis was 20%, the concordance was 69%, and the rate of underdiagnosis was 10%. So this shows that the colposcopic should be performed by experienced physicians. Next. So what is the role of cervical cervix biopsy? The cervix biopsy is recommended when there is persistent untreated dysplasia or significant risk factors for persistent dysplasia such as smoking, immunosuppression, HIV, or if there is a progressive disease, or if the patient is non-compliant or she'll not come for the further follow-up, or lesions which are highly suspicious for invasive cancer. To prevent excessive bleeding after biopsy, we can apply a prolonged pressure with a large swab, or the hemostatic preparation with Monstell paste or silver nitrate may be safely considered. Or if there is still excessive or uncontrollable bleeding, fine suture or vaginal packing may be helpful. Endocervical curettage and endometrial biopsy is strongly contraindicated. Next. So what are the results we can expect after colposcopy? It is CIN1, low-grade lesion, CIN2, CIN3, AIS, and cancer. If it is a cancer diagnosis, we need to directly refer to them a gynec-oncologist. Otherwise, CIN1, 2, 3 can be managed. Next slide, please. So natural cause of CIN pregnancy. During pregnancy, there is overexpression of sex hormones, that progesterone, estrogen, and other hormones, which may facilitate cervical carcinogenesis by induction of squamous metaplasia in the transformation zone and modification in the local immune system. Hence, there is usually persistence of these lesions in the pregnancy, and this it can be one of the reason in postpartum there are high chances of clearance, because once in postpartum there is a drastic fall in these hormones, and this helps in increased regression. So what is regression of lesion? It is defined as a lower grade colposcopic finding or a pap smear or a histological lesion being detected in the postpartum period in comparison with the first examination during pregnancy. Persistent disease is defined as colposcopic finding or a pap smear or a histological lesion of the same grade at the time of initial diagnosis in comparison with the final postpartum histology. Disease progression is defined as colposcopic finding or a pap smear or a histological lesion of a high grade at the postpartum histopathology in comparison with the initial consultation. Next slide, please. This is one of the table which shows multiple studies which have shown the regression of lesions in low grade and high grade. So in low grade, there is approximately 70% of the lesions regress in the pregnancy, and in high grade lesions we can say at least 30 to 50% of the lesions regress during pregnancy. Next slide, please. These are also multiple studies which have shown that regression of CIN 1 to 3 or CIN 3, it is at least 45 to 70% of the cases regress in postpartum. Persistence up to 20 to 60% of the case persists, and there is at 3 to 13% of cases progress to invasive carcinoma. And there are one or few studies which have shown that mode of delivery, that is after vaginal delivery, there is increased regression compared to cesarean section. Next slide, please. So whether the delivery mode can affect the possibility of regression of dysplastic lesion remains controversial, but there are certain theory which is supportive that the cervical trauma that occurs during delivery may lead to inflammatory process in the epithelium of the cervix, which may promote repair mechanism and cause regression of the lesions. There is also transient ischemic changes that occur in cervical tissue during ripening. This also helps in enhancing the regression in the postpartum period. Also, there is cervical ripening, and the passage of fetus to the birth canal may lead to the loss of dysplastic cells, which can again help in a regression of the lesion. So these are some of the theories which have shown that there can be regression of these lesions if there is vaginal delivery. But there are other few studies which have showed there can be the results are similar. Next slide, please. Next. Okay. So how to treat these CIN lesions? The current consensus recommendations reflect an overall conservative approach in absence of any frank invasive cancer during pregnancy. It has been reported that selective treatments for high-grade lesions such as cold knife conization or a LEEP can lead to bleeding, miscarriages, premature birth, high incidence of complications. Hence, it is contraindicated unless there is invasive cancer or suspicious of invasive cancer during pregnancy. In cases where AIS or invasive cancer is identified, referral to a gynec oncologist is the preferred course of action. Next slide, please. Next slide. So the frequency of follow-up depends upon the stage of the pregnancy, the severity of the lesion, and the patient's risk of being lost to follow-up. So on cytology, if it is low-grade lesion or ascus, then it does not necessitate any intervention because the rate of progression to invasive cancer is very low. Maybe once in postpartum after 12 weeks, we can just do a cytology, repeat cytology to see what is happened. But if it is a high-grade lesion on cytology or a glandular abnormality, they have to be referred for early colposcopy to rule out any invasive cancer. If the high risk HPV positive 16 or 18 is positive in pregnancy, they should be referred to colposcopy as early as possible. If it is other high risk HPV other than 16, 18, it can be triaged with cytology or a colposcopy and then taken decision accordingly. Next slide, please. Those with colposcopic impression of CIN 2 or 3 should undergo a surveillance colposcopy every 12 to 24 weeks, and they can be reviewed again in postpartum after 6 to 12 weeks. If there is high suspicious of invasive cancer, then the biopsy is recommended. Otherwise, it can be followed up every 12 to 24 weeks, and again it had to be reviewed in postpartum after 12 to 24 weeks. Next slide, please. So this is the WHO recommendation in pregnancy. The preferred test is high-risk HPV DNA testing, which is superior to pap smear. Routine screening is not recommended, but if a woman is can happen at any time using proper equipment. If it is high risk HPV detected, referral for early colposcopy is advised. If the other high risk HPV other than 16-18, then they have to be triaged with cytology. If cytology of low grade, then repeat testing should be done in postpartum 3 months. If it is high grade lesion, then early colposcopy is needed. So how do we manage the abnormal results? It's the same, like, you have to, for all high grade lesion, colposcopy should be done. Colposcopy is safe and recommended for abnormal screens. Biopsy is performed only if there is suspicious of invasion or high grade lesion. And for confirmed CIN 2 or 3, while after colposcopy or a histopathology, monitoring with repeat cytology or a colposcopy every 8 to 12 weeks until delivery is common, because most of these lesions often regress once the patient has delivered. With the treatment, generally treatment is delivered until delivery to allow for the normal healing and accurate assessment. It has to be better done 6 to 12 weeks after postpartum. Once again, colposcopy or a repeat cytology HPV can be done, and then the decision can be taken for a appropriate treatment, that is LEAP or a conization. Next slide, please. So this is the ASSCP guidelines. Patients diagnosed with high-grade lesions during pregnancy should undergo surveillance via colposcopy and age-based testing, depending upon cytology or HPV every 12 to 24 weeks. Repeat biopsy is recommended if the lesion worsens or invasion is suspected. Avoid any kind of excisional treatment unless cancer is highly suspected. Postpartum colposcopy is recommended after 4 weeks after delivery. Maybe appropriate is 6 to 12 weeks postpartum. If a lesion is found at the time of postpartum colposcopy, biopsy and excisional procedure can be decided. Next slide, please. So this is the chart from Australian guidelines. So they have made a statement that cervical cancer screening during pregnancy is safe and should not be delayed if the patient is due or overdue. The age eligibility is any women is more than 25 up to the years of 74 years. And patient under 25 years, if the patient is having any signs or suggestive of cervical cancer, then she has to be investigated with co-test, that is HPV and LBC. Otherwise, cervical screening is not recommended for women, including pregnant women under the age of 25 years. So pregnant women should be given a choice of testing option, either a clinical collected cervical sample or a self-collected sample. If it is clinically collected sample, it is recommended to use cervical sampler broom. Self-collected vaginal samples are sensitive for detection of HPV and CIN2 as clinical collected test. HPV self-collection is suitable for use at all stages of pregnancy and may be more acceptable option for some women. Women testing positive for HPV but not 16 and 18 are called for or advised to return so that a cytology triage is done with LBC, and then based on the reports we can decide whether colposcopy has to be done or whether they have to kept on observation. Next slide, please. Next slide. So how do we manage these abnormal results? This is again the guidelines from the Australian guidelines, screening guidelines. So when the patient or pregnant woman has been positive with any of the high grade lesion or a cytology reports, we have to reassure the patient that HPV is very common and it usually cleared independently by the body. A positive HPV result does not mean they will have or will develop cervical cancer later on. If HPV is not detected, return to next screen in 5 years. If HPV other than 16 and 18 is detected, reflex LBC. If it is negative, repeat the test in 12 months. If reflex LBC is positive for high-grade lesion or glandular abnormality, we have to refer them for a colposcopy. If HPV 16 and 18 is detected, directly refer them for colposcopy regardless of LBC results. Colposcopy during during pregnancy is safe and should not be delayed. It is basically to exclude the presence of any invasive cancer and to reassure the patient that their pregnancy will not be affected by the presence of abnormal cervical screening test result and should be taken by a colposcopist experienced in assessing women during pregnancy. So if a woman in pregnancy, if the report of LBC is HSIL, then colposcopy should be done. If a colposcopy, the transformation zone is type 3, then we have to repeat the LBC and colposcopy at 28 to 24 weeks. If it is still the same, like type 3 transformation zone, and if there is no change or if it is suspicious, then take a biopsy. Otherwise, we can repeat it in postpartum 6 to 12 weeks. If the transformation zone is type 1 or type 2, and if the transformation zone is normal, then the colposcopy can be repeated postpartum at 6 to 12 weeks. If the transformation zone is abnormal and the colposcopic impression is CIN 2 or 3, colposcopy should be repeated at 6 to 12 weeks pregnancy postpartum. If there is suspicious of invasive carcinoma or high-grade lesion, then better to take a biopsy, and then the decision taken according to the biopsy pathology. Next slide, please. So these are the guidelines from several countries like PHGO, RCOG, ESCO, ACOG, SOGC, and RANSOC Australia. So the routine screening is for every woman, if there is an overdue or if it is due, then the first prenatal visit only pap smear to be done. Either it can be HPV testing or a cytology, whatever is available in the clinic. If there is any abnormal results, that is high grade lesions or glandular lesions, or if high risk HPV is detected, then colposcopy is recommended. Colposcopy is safe during any period of gestation. Biopsy is performed only if it is HCIL or there is a suspicion of invasive cancer. The follow-up is close monitoring every 6 to 12 weeks with colposcopy and cytology, and the treatment should be deferred only postpartum 12 weeks. Till then, the follow-up should be done, and the final follow-up should be done within 6 to 12 weeks postpartum. And based on that, we can further evaluate either with a cytology or a colposcopy or HPV, and then take a decision based on the histopathology treatment. Next slide, please. So this is a take-home message. CIN during pregnancy is managed conservatively, but important thing is invasive carcinoma to be ruled out. Most cases of CIN remain stable or even regress after delivery, and progression to invasive cancer is rare. Colposcopy is considered safe and does not increase the risk of pregnancy loss, and it has to be performed by experienced physician. Thank you.
I think, Pratima, that was absolutely excellent. It was really, really fantastic. And so many new things, no, we've learned. As we always think that, we are done with colposcopy. Now there's nothing more to really imbibe. And especially all those lovely points that you gave about doing colposcopy during pregnancy, and how it is a vaginal delivery which actually enhances the chances of regression of the lesions rather than otherwise. Otherwise, generally one would, you know, uh, I will not say that it used to be the teaching, but it was used to be the general impression that if there are lesions, there's any CIN of any sort, then a cesarean is perhaps better. But I'm pleasantly surprised, and thank you so much for sharing this, that vaginal delivery is in fact much better. Thank you so much.
Thank you, ma'am.
Thank you, Dr. Pratima, for that elaborate talk.
Thank you, Dr. Pratima. And thank you, everyone, for joining this session. I think you all have learned something from this session. Thank you so much. We look forward for further sessions in future. Thank you.
Ma'am is here. We can have comments from ma'am also. Hello?
Yeah, Bindya, are you referring to me?
No, I was referring to ma'am. She had Okay, then I think Rupinda ma'am has very well summed up the comments, and she is absolutely right, Dr. Pratima. Excellent job, very well crisp and to the point messages. It's so difficult to do colposcopy and other managing CINs in pregnancy. Very, very crisp lecture and excellent take-home messages and very informative panel. Thank you, Dr. Premlata, and thank you so much, Dr. Shobha, for such an excellent panel. Very nice webinar convened today. And thank you all for attending this very informative webinar. Today we had a very good attendance of 160, and so the family is growing. Many more and more are joining this webinar. So once again, thank you very much for all joining in, and till next week, the next month again, 7th of May, 7 p.m. for 70 minutes, we'll meet again. So Dr. Nidhi Gupta is the convener for the next webinar, and we'll have a very important discussion on the role of artificial intelligence in cervical cancer screening and colposcopy. So till then, everyone, Good night. Thank you very much for joining. Once again, thank you, Dr. Pratima, for such an enriching webinar today. And thank you, Dr. Aruna. Any comments from you?
No, thank you. Wonderful, and most importantly, covered everything and finished in time.
Yeah, thank you, Dr. Aruna and
Yes.
Dr. Bindya, for
Thank you,
the
ma'am.
very, very excellent execution of everything.
So much.
Thank you so much.
Thank you so much, ma'am.
Thank you
And
so
from
much.
tomorrow, we are starting the colposcopy training, and it's very
Thank you
exciting
all
to
for the
share that
opportunity.
this time 70 FICCP trainees registered for the course, and still more and more are joining till every day 5, 6 are adding every day. So the tribe is growing. So thank you everyone for this.
Congratulations.
Yeah, and I
Congratulations.
definitely have to
New leadership
congratulate.
of ISS.
I have to congratulate both Aruna and Vindhya and Bhagya.
Yeah.
I mean, it's just a fantastic setup here.
Yes.
I'm glad I was invited for this and I joined. And Pratima, beautifully done. Thanks a lot. Thank you all. Good night.
Thank you, Rupen.
Thank
you.
you. Thank you.
Thank you
Thank
all.
you all.
Thank
Thank
you.
you for the opportunity.